Hello, my name is Nada. I'm here to present you patient case of LM. She is a 62-year-old African American female who was seen today in the internal medicine clinic for a follow-up appointment for blood pressure evaluation and overall medication management. LM was seen in the clinic 2 months ago and was started on atorvastatin at that time. Her previous blood pressure measures were 161 over 87 and 164 over 83 were repeated. She says she has been trying to cut salt out of her diet and walking more. She is willing to pursue drug therapy for any and all of her conditions. However, she is not interested in quitting smoking at this time. Past medical history: she has hypertension, dyslipidemia, and arthritis. Family history: her mother deceased from dementia, father alive and has hypertension and heart failure. Social history: she is a current smoker, smokes 1 pack per day, walks for 15 minutes daily, and she's married for 35 years. She has allergy to penicillin with hives. The medication that she is taking is atorvastatin 80 mg once daily, multivitamin tablet one tablet once daily, Advil 200 mg, one tablet 4 times as needed for arthritis pain. High priority problem is hypertension and cardiovascular medication management. Low priority are dyslipidemia and arthritis. For the assessment of hypertension, the patient is experiencing uncontrolled stage 2 hypertension as evidenced by her current blood pressure, which is 162 over 85 and 165 over 86 when repeated. She was seen 2 months ago and her blood pressure was almost the same readings, while she had similar reading in a pharmacy blood pressure measuring machine, and this rules out what is called white coat hypertension. Her hypertension is not related to medications or diseases she has, so it is not a secondary hypertension, especially the lab test came with negative micro and macroalbuminuria. Therefore, all these findings confirm diagnosis of essential or primary hypertension. Also, this patient has hypertension but without compelling indications, such as chronic kidney disease, diabetes mellitus, heart failure, myocardial infarction, PAD, angina, or coronary artery disease. Contributing factors are age, race, ethnicity, gender, cigarette smoking, family history, since her dad has hypertension, and OTC Advil that she is taking. The patient is not taking any medication for hypertension, but has been trying to cut salt out of her diet and walking more. Goal of therapy is to reduce associated morbidity and mortality from cardiovascular event. For assessment of hypercholesterolemia, it seems is controlled according to her recent lab panel, with total cholesterol 162, high density lipoprotein 50, low density lipoprotein 78, which are within normal limits. However, her triglycerides are still above level with reading of 168, but comparing to the previous reading, the patient is responding greatly since the reduction is almost 38%. The patient has a 10-year atherosclerotic cardiovascular disease risk factor of 18.4%, which is considered high. For the assessment of arthritis, it appears to be controlled since the patient has no concerns about it. and Advil seems to control her arthritis pain well. Her vitamin D25 is in normal level. The patient's lab tests show normal blood glucose with 2 hour glucose challenge of 111 and A1C 4.5%. Also, she has normal TSH, renal and liver functions. She just has low serum creatinine, which may be due to low protein intake because the patient does not have other causes such as severe liver disease or muscle dystrophy. For the plan, I recommend both pharmacological and non-pharmacological therapies for this patient. Non-pharmacological therapies such as DASH diet, physical activity for 30 minutes, at least for 5 days per week, at least 5 days per week. Smoke cessation, maintain normal body weight with body mass index to be 24.9 or less and reduce salt intake. The pharmacological therapy initiate lisinopril 10 mg once daily and hydrochlorothiazide 12.5 mg once daily. Those doses should be titrated up to 20 mg and 25 mg once daily respectively for both lisinopril and hydrochlorothiazide. The titration should be within 2 to 3 weeks if the patient tolerates the initial doses. Also, this patient should continue taking atorvastatin 80 mg once daily. The target blood pressure for this patient is 183/80 by guideline, and this patient won't have to follow up within 4 weeks to reassess medication's efficacy and non-pharmacological patient response. The rationale behind this, according to guideline, stage 2 hypertension should be treated with 2 or more antihypertensive agents with different classes or mechanism of action. Section 10.1.1 in the ACC/AHA guideline 2017 shows that Black patients and other patients age 60 and above or more tend to have greater antihypertension effects with calcium channel blockers or thiazides, and this makes them ideal as first-line monotherapy or as initial agents in multiple drug therapy for those populations. Recommendations number 58 in dyslipidemia guideline 2017 presents that further reduction in low-density lipoprotein cholesterol for high-risk patients beyond established target using statins, leading to more reduction in atherosclerotic cardiovascular disease. This comes with grade 1 level of evidence A. And here atorvastatin 80 mg is considered high-intensity statin and suitable for this patient since the patient has a high 10-year ASCVD risk, which equals 18.4. The non-pharmacological therapy are recommended by ACC/AHA guidelines for controlling hypertension and also for the dyslipidemia, and so this will reduce CV event. Non-pharmacological therapy provides 20 to 40 mmHg reduction in the systolic pressure according to American Family Physician if the patient abides to it. Okay, so for monitoring, we'll monitor reduction in blood pressure for both, regarding both lisinopril and hydrochlorothiazide. For lisinopril, we want to monitor also the serum creatinine, BUN, potassium, and we will consider baseline LFTs, liver function tests, and monitor for jaundice as a sign of liver failure. Regarding the hydrochlorothiazide, we would also monitor serum and urine electrolytes, uric acid, blood glucose, renal and liver functions. Patient education is so important, and we want to encourage this patient for smoking cessation, because smoking cessation leads to a great reduction in blood pressure and helps a lot in controlling her hypertension. This patient also should be aware of side effects she may experience from those antihypertensive agents. For example, lisinopril causes hypotension, dizziness, high serum creatinine, syncope, headache, and cough. Hydrochlorothiazide may cause hyperglycemia, hypotension, dizziness, headache, and electrolyte disorder. This patient also should avoid systemic nonsteroidal anti-inflammatory when possible, and consider alternative analgesics such as acetaminophen, or use topical nonsteroidal anti-inflammatory. Adherence to medication is crucial and plays a major role in controlling diseases. This patient also is better for her to get flu vaccine. There is a couple points I want to discuss regarding the primary prevention for cardiovascular events as requested by this patient. The United States Preventive Service Task Force guideline addresses that the decision to initiate low dose of aspirin for patients 60 to 69-year-old who have a 10% or greater 10-year cardiovascular risk should be an individual decision, and this comes with grade C level of evidence. So I searched for trials to support my finding, and I got that prophylactic dose of aspirin 100 mg does not show any benefit in reducing the risk of major cardiovascular events, risk of total stroke, ischemic stroke, hemorrhagic stroke, and no significant effect on the risk of myocardial infarction or death from cardiovascular causes. I also found that the patient does not fit the COMPASS trial inclusion criteria, since participants there in that trial had at least one cardiovascular event, and they were seeking secondary prevention using rivaroxaban alone or in a combination with aspirin. So for this, I don't recommend aspirin or rivaroxaban for primary prevention of cardiovascular disease for this patient. Thank you.